Good afternoon, ladies and gentlemen. Welcome to your destination of the latest medical trends, Medcast. Today, we are so pleased to have Dr. Abdulrahman AlKanderi, who is a senior specialist in urology and genitourinary surgery. Welcome, Dr. Abdulrahman.
Thank you so much for the interview. Thank you for you and for the team. I hope it will be informative and easygoing.
We had a very beneficial speech in the last episode, and we need to continue that speech because we didn't have enough time to discuss the details of the kidney stones. Now,
Definitely.
in the last episode, we have discussed the formation of the kidney stones and what are the complications that may arise after having the kidney stones. Now, we need to know about the treatment plan you would set for the patient if he's diagnosed with the kidney stones.
Great. So the treatment plan depend on multiple factors. Number one, the clinical status of the patient. So if I have a patient coming to me with a special clinical status, I have to go for emergency treatment.
Mm-hmm,
And the indication for emergency surgical treatment are if the patient has a fever with a kidney stone,
mm-hmm,
we have go immediately to like drain the obstructed urine. Obstructed urine above the kidney, especially if it is in the ureter, will put the patient in very high risks to be in a sepsis,
mm-hmm,
and sepsis is fatal for the patient. So this is number one. Stones with a fever, obstructing stones, especially with a fever, will go immediately to the surgical therapy. If the pain is severe and he cannot tolerate it, even with the painkillers, I go immediately with the surgical therapy.
mm-hmm.
If the patient is high risk jobs, like he's a pilot, for example, you don't want a pilot like
To
driving
get
his
in pain
airplane
while
and he
he's
got
driving,
pain.
yeah.
It's very risky for him and for the other people. So we go for the surgical treatment immediately. Patient has repeated vomiting, we go. If it is affecting the kidney function, also we have to go for the surgical therapy just to prevent any damage to the kidney. What other treatment options we have? If all of this is negative and the patient is very happy, he had a one attack and he's very well controlled with
A
with
bit
a
stable.
painkiller, no fever,
Mm,
kidney function are good. We go for a conservative management.
mm,
So we recommend the patient to do some recommendation for the fluid intake, high fluid intake stuff, and just give him painkiller in case of any pain. He should have a painkiller and give a chance for the stone to pass. And this category of patient, we keep it for small stones,
mhm.
especially in the ureter. So
And that decision is taken after you get the CT scan.
CT
Yeah.
scan, correct.
Mm,
CT scan is the best for us just to show us where's the stone, what's the size of a stone, and can we wait or we cannot.
mhm,
So conservative management is an option. We can add some medication. We call it medical expulsive
mm,
therapy. This is painkillers. Some treatment group of family called alpha blocker help us to dilate the ureter just to increase the chance of a stone to pass. If the stone size is less than 4 millimeter, 80% it will pass. If it is in the distal
mm,
ureter, 46 millimeter to take 60%. More than 6, the chance is low. I'm talking about only 20% to
mhm,
pass. So if the stone is big in the ureter, we recommend the patient to go for surgical therapy because the chance is very low to pass.
mhm.
So multiple factors will lead us to manage this patient.
Okay.
Now, if we talk about the surgical therapy, this is a big dilemma. So I'll divide it if it is in the kidney, the ureter, or
Yeah.
in the bladder.
Depends on the location.
Correct. So if the stone in the kidney, we'll look to the size. Size, I'll divide into three categories. More than 2 centimeter, 1 to 2 centimeter, less than 1 centimeter. If we are talking about any stones more than 2 centimeters in the kidney,
Mhm,
the first line of management, what we call the percutaneous nephrolithotomy. And this is procedure is easy procedure and it's very common. It's done, I think, all hospitals in Kuwait. We just make a small incision in the skin and going immediately from the skin to the kidney from the back.
through endoscopy, yeah.
Yeah, we dilate the track, we insert a sheath, and then a scope will go through this sheath directly to the stone.
Mhm,
The advantage of this procedure, it will give us a very high stone-free rate. Stone-free rate mean that we finish the stone from one session.
mhm,
So because we have a big sheath and big scope, and we have a big lithotripters instrument that we use to destroy the stone and fragment the stone, so we can finish even big, huge stone with this technique. Okay, this is for more than 2 centimeter. Another option, if the surgeon cannot do this procedure because this procedure needs special training or it is not available, for example, for any reason, we have the second line of management, which is we go through the P hole with a special scope, a small scope, going all the way up to the kidney and the fragment stone with the laser.
Mhm.
The beauty of this technique, it's very safe, easygoing. All the urologists can do this procedure. But if it is more than 2 centimeter stone, the stone free rate is not that much. So maybe the patient will require 2 procedures to finish the stone. Now we'll go for 1 to 2 centimeters. All the options are good. I'm talking about the PCNL, which is the percutaneous nephrolithotomy, or the flexible ureteroscopy, which is the small scope will go from the pee hole.
From the
It's
pH, yeah.
good as well. And also we have the shockwave lithotripter. It's very easy procedure. It's
Is it invasive or non-invasive?
non-invasive at all. Under local, we can do it. Even like we just give the patient some painkiller, like paracetamol, and the patient will have a session. Basically, it's a sound will go from the skin all the way to the kidney to the stone and fragment the stone. Just melt it and make it small, and the patient will pass it with the urine. So 3 options for 1 to 2 centimeter in the kidney.
Okay, for which option would you decide to put a stent for the patients?
Yeah, stents is another story. So stents, it's bothering. And we need a lot of research just to develop the stents because really a lot of patients are complaining of this. Stent post the procedure, after the procedure, has a special indication. If we found any ureteral inflammation, we prefer to insert a stent after the procedure. If we have small fragments, we will put a stent just to avoid accumulation of this fragment and causing obstruction. During the procedure, sometimes we have some mucosal injury to the ureter. It's not risky, but I don't want this laceration to be healed in the fibrosis and cause a stricture. So I keep the stent just to have a proper healing of the ureters. So stents, I would say that 80% of the patient, unfortunately, insert stents, and some patients are really bothered from them. If the stone is small, so we have less than 1 centimeter stones, the shock wave become the first line of management because it is less invasive and good chance to pass the stones. Flexible also are good, but the percutaneous nephrolithotomy considered to be invasive for this small stone.
Because I think it's the most complicated procedure you may go with.
Correct.
Now the question is, after the symptoms you have mentioned and the decision you have made for the patient to make the surgery, does that mean that the kidney stones are only formed with certain kind of patients that are like, let's say, above 45 years old, or it can happen at any age?
Any age, even in the pediatrics. We
Even
have,
in pediatrics?
yes, we do have pediatric forming a stone, and most of them will have some metabolic diseases that cause a lot of stone formation. So we do this procedure, kind of procedure for even the
It
pediatrics.
could be like a family history of having recurrence of forming the stones.
Correct. Genetics, family reasons, metabolic diseases lead for more stone
Okay,
formation.
that's great. After you take the decision to make the surgery, and especially with those patients that you use the stents inside, does that mean the patient need to follow up with the urologist from time to time and use some medications to keep the stent safe, to keep the patient safe after finishing the surgery?
This is the, I would say, advantage or disadvantage. I don't know if the urology patient. So we don't leave patients
Forever.
forever.
You build up a relationship between you and the patient.
Forever, all diseases. At least we see them once yearly, especially
So
for
either
stone
if they
formation.
are having recurrence or not.
Correct,
Yeah.
correct. Because the patient, as I said before, maybe earlier in the previous season, yes. If the patient form a stone, he will have a 50% chance to form another stone. So for any patient with stones, we will recommend him just to do imaging, ultrasound, even
Just in case.
just in case.
Yeah.
So we see them a lot. Basically, after the surgery, we have to see them 2 weeks after the procedure just to confirm everything is good. And we are able to remove the stent. After we remove the stent, we see them 3 monthly. 3 months, we do ultrasound usually just to check the ureters, any complication happen to them, because it will be a long-term complication for the ureter. So we see them 3 months. If they are good, we can see them after a year.
A year or like each
Correct.
6 months.
Correct.
But do they need to be like on certain medications? Sometimes, after the surgeries, some patients might be on anticoagulants or something. So do you have any recommendation for some sorts of medication that the patient should use after the surgery?
100% correct. So this is depend on the stone type. So what usually routinely when we do our procedures, we have a small part of your stone and put it for analysis.
Yeah.
This analysis will show us what type of stone you have: calcium, uric acid. We have multiple types of stone, cystine stone, and each stone has a treatment that help us to prevent another formation
In
of
the
the stone.
future.
Correct.
That's great. Now, one more last questions. I know you have mentioned that after 2 weeks you might have the decision to remove the stents from the body, but is there any other cases that you might need to keep the stents for longer period than 2 weeks after the surgery?
Correct. So routinely we keep the stent for a week, only
Mhm.
a week. No need like 2 weeks. So a week we re-image the patient, no fragments, we can remove it. Sometimes when we have a urethral laceration or urethral injury in the procedure, we would like to keep the stent longer. I'm talking about 4 to 6 weeks.
But not longer than 6 weeks. So, and let's say in very rare cases, you
Very
might
rare.
have decision to keep it for longer,
Correct.
but mostly you would remove it after 6 weeks.
And maybe before, like 6 weeks is the rare thing. Just
Yeah,
to
well, I
make
mean, mostly, let's
yeah,
say.
yeah.
Okay.
Just to make it easy for the audience, the stent is maximum to stay in the correcting system 3 months. We cannot keep it more than this.
Oh, okay. So in any case, even if you want to
Keep it,
you
we'll
have it,
exchange it.
we'll exchange it after 3 months.
Why? Because it will be a very nice area to form another stone. So it will have
Yeah.
incrustation and then will stuck.
Yeah.
And we cannot remove it later on.
Dr. Abdulrahman, we are so pleased to have you today. Hopefully, we can meet you again in our program.
Thank you so much.
Thank you so much.
Take care.
Our dear viewers, we have reached to the end of our segment with Dr. Abdulrahman AlKanderi. Hopefully, we can see you again with another healthcare specialist. Until that time, see you later.